Okay, so everyone, welcome to our ninth session of the MedAI group exchange sessions. So this week, we are glad to have Amara Tariq with us to talk about her research on patient-specific COVID-19 resource utilization prediction using Fusion AI models. Amara is a postdoc fellow at the bioinformatics department at Emory University. Her work encompasses analyzing electronic medical records, imaging studies, and clinical reports and notes for intelligent decision-making regarding disease management and healthcare resource optimization. So as always, let's try to make this session as interactive as possible with some good audience participation. Before we start, Amara, do you have any preference regarding how you would like to take in questions?
You can interrupt me anytime you have a question.
Okay. All right, so without further ado, let's hand over to Amara to introduce her research.
Hi, everyone. I'm Amara Tariq, and I'm going to talk about a recent work on COVID-19 patients' data. I'm hoping everyone can see my screen.
Yes.
It's okay. Okay, so the work I'm going to talk about is about healthcare resource utilization prediction for COVID-19 patients. So basically, the idea is that for a COVID-19 patient, trajectory of disease may look very different. Some of the patients, they may just go home and quarantine, and some of the patients, they might end up needing hospitalization. Even out of those who need hospitalization, if they suffer some, symptoms like acute respiratory distress or organ failure, they may have to go to ICU. So, and they may need a pulmonary or they may experience pulmonary or cardiac events. All of these clinical events, they point to healthcare resource consumption. For example, if somebody needs to go to the hospital, they'll need a hospital bed. ICU admission, ICU bed. If they go through pulmonary or cardiac event, they would need pulmonary or cardiac specialists and equipment. So disease trajectory can point to what kind of healthcare resources would be needed. So the goal was to be able to predict these clinical events based on the EMR, electronic medical record data that we have available for these COVID-19 patients right at the time of RT-PCR testing. So there have been lots of studies to indicate is somebody, or what are the factors that would mean a poor outcome of the disease, or maybe severe trajectory, a severe severity of higher severity of the disease for any patient. And there have been in literature they can point to D-dimer levels or maybe even race or ethnicity as indicators of who would need for which patients basically the disease trajectory would look much worse than other patients. But there hasn't really been any comprehensive quantitative analysis of how different factors that we have available already in the EMR data, they may play out in this kind of disease trajectory prediction. So our goal was to be able to incorporate all of the different factors that we have available already in the EMR data and be able to predict disease trajectory with the eventual, and that disease trajectory would eventually be able to predict healthcare resource utilization, future utilization of healthcare resources. So this work has recently been accepted for publication in NPJ Digital Medicine. This is what our problem formulation looks like. We went back and forth with the physicians in our team to figure out what would be the best prediction time point for our model. Like when should we be able to predict the event of hospitalization, how far in advance that would be useful. So it turns out that the time of RT-PCR testing, when the patient tests positive for the COVID-19, that's the time when we would like to predict whether that patient would just go home and self-quarantine, or that patient would need to go to hospital. So as you can see, we have EMR database, and we have lots of data, basically temporal data available for each patient. So temporal data, because patients may have been coming to the same healthcare facility for a year or so, or maybe in the past year. So we have multiple encounters of that patient. And then we have recent encounters of that patient as well. So if this is the point of RT-PCR testing, then we have, recent encounters, and we have like historical encounters of those patients as well. And based on all of these encounters, based on all of this data, we want to be able to predict right at this time point whether the patient would need hospitalization within 7 days of testing positive, or the patient would just go home and would not need hospitalization. So that becomes our problem formulation. I would talk about why this was a technically challenging problem for us, given certain characteristics of the data. Just a few.
Actually, ask a quick question.
Sure.
So the current encounters, are they necessary that they should be COVID related, or or COVID symptoms related, or are those?
No. Okay. No, I mean, we are collecting everything that is there in the EMR. So whatever kind of encounters they've had. The idea is like whatever you type of encounters you've had with the healthcare system in the recent past, they may play a role in how what trajectory your disease would take.
I see.
So with that in mind, with it.
So the current is just a time frame that you.
Yeah, current is just a time frame.
Okay.
Current is basically if you can treat this as a time line, then this is current because it's closer to the time of prediction, and this is history because it's further away from the time of prediction. I'll talk about the exact formulation in a bit. Okay, and this is just the cohort selection. We had patients coming in the 12 centers of MD Healthcare Network. So we selected about 3,200 patients with the RT-PCR, with confirmed RT-PCR positive tests. And then we divided, then we looked at whether or not they were hospitalized, hospitalization versus versus the patients who were not hospitalized. We even had ICU admission data available for the hospitalized patients as well. And overall, our cohort consisted mostly of African American patients with the mean age of about 57 years. These are some of the data characteristics that we were dealing with. We figured out with the help of our physicians what are the important comorbidities in the case of COVID-19. So respiratory disease, hypertension, renal disease, or diabetes. They seem like four important. They are the four important comorbidities. This is just age-wise distribution and race-wise distribution, as well as ethnicity-wise distribution of these comorbidities. As you can see, there is a correlation between disease and the age. Obviously, patients older in age, they tend to have this disease. The higher proportion of those patients tend to have this disease. Similarly, race-based analysis shows us that African American population, they seem to be disproportionately affected by respiratory disease and hypertensive disease. So now I'm going to talk about some of the challenges of the kind of data that we were dealing with. As always, like if you're dealing with EMR, everyone has to probably deal with the missing data because data is never complete. You always have missing entries. You need to deal with them. Data sparsity was a big issue in our data set because COVID-19 presented us with a scenario where patients may just come into the hospital basically just for COVID-19 for the first time. So we don't really have like very kind of historical information about that patient. On the other hand, we also have patients in our cohort who have been coming to MD Healthcare Network for years. So we have like very dense information, very dense historical EMR information about them. And on the other hand, we have patients who have very little information available about them, especially historical information. Then the other problem was cohesive featureization from multiple data sources. EMR consists of multiple sources, multiple data sources. We have demographic information, we have medication, lab results, we have also comorbidities, we also have CPT codes. So we wanted to keep our feature engineering as minimally supervised as possible. There's been a lot of work in literature when we were doing the literature survey. It turns out people were mostly interested in mortality analysis, factors for that would affect mortality. And most of the studies that we came across were handpicking or selecting features for prediction based on expert opinion. We wanted to basically avoid that, include as many factors from EMR as possible so that eventually we have a quantitative analysis of all of those factors. And then the model figures out which ones are important for the prediction important clinical event. So we wanted minimally supervised feature engineering, and the temporal data modeling as EMR data is temporal in nature. Patients have multiple encounters over time with the healthcare facilities, where they build up a temporal a feature vector for them. But the problem is, since the data is really sparse and data is basically very uneven for different patients, so we have to come up with basically uneven interval based temporal modeling. I mean, in literature, you can find basically quarterly featureization. I mean, you treat each 3-month period as one quarter, figure out a feature vector for that, and then another quarter, then another quarter, and then you just concatenate them. These types of techniques, they weren't really working for our data because many of the patients were then, all of the historical quarters would be just empty. So we came up with this history versus current interval-based scheme. So current is basically last 15 days for us, and counting from the point of RT-PCR positive testing. So when you test positive for RT-PCR, what has happened to you between the past 14 days? Actually 2 weeks. So that's our current interval. We create a feature vector from there, and then we have the history interval in which we include everything from the past year. So that's the history interval, and history and current interval, they're eventually concatenated. And this was, in our experiments, this came out to be the best approach, given given the characteristics of our data set. I'm going to talk about different EMR data sources. So basically, we ended up using 5 different sources: demographic, CPT, ICD-9 codes, medications, and lab results. So demographic information, we have age, race, gender, and ethnicity. Most of these there can be easily encoded as one hot, basically as categorical features, except for age. You could always bin age. We went with a normalized representation of age. CPT codes, we did frequency-based filtering once again, since we wanted to keep it as minimally supervised as possible. So we simply went with frequency-based filtering and picked out if we set up a frequency threshold. If the CPT in our data set occurs more than that threshold, we pick it up as a potential feature. ICD-9 and 10 codes, medication and laboratory results. I'm going to show one by one how how did we create features from them. So ICD-9 codes, they have a nice group structure. So we decided to use that group structure for our featureization. So this is one sample group. For example, diseases of respiratory system, we have ICD-9 ranges for each subgroup. So chronic obstructive pulmonary disease, it has range of 490 to 496.99. So we treated each of these subgroups as one feature. If the ICD-9 code is available in the EMR for a patient, we set this subgroup-based feature as present versus as absent if nothing from that range is available. So this is just a sample. We basically used all of the ICD-9 group structure to encode ICD-9 information in our next. And once again, we have since we have temporal modeling, we have feature versus current current interval. So we create an ICD-9 feature from the current interval and another from the history interval. Medications, we made medications, they were grouped based on their function. So once again, this is just one. These are just a few examples. So these are just 3 basically medication groups. So we basically took frequent medications and asked our physicians to group them based on their function. So each medication group acts as one feature. So if patient was prescribed any medication from that group, that feature is set to present as opposed to absent. The same goes for laboratory tests. We again did frequency-based filtering and we encoded top most frequent laboratory results as normal, abnormal, or unknown. So through literature, we had basically lower and upper values, basically normal range for each of our lab tests. So if the value reported for the patient falls within that range, it's normal. If outside of that range, it's abnormal. If the test was never performed or has not been made part of the EMR of that patient, it's coded as unknown. So that's how we ended up using lab results. So this gave us large feature vector. I think we ended up with a few hundred basically features coming from all of these different modalities when we combine them all. As I mentioned already, for temporal modeling, we went with this current versus history approach. This is uneven and current interval is much smaller than the history interval, but this was the best formulation for the type of data we had. Then came the modeling part. How, since we have this large feature set and we want to like automatically figure out which factors are more important when it comes to the prediction of disease trajectory. So we obviously went with fusion modeling, and we tried 3 different types of fusion models: late fusion, early fusion, and middle fusion. Basically, each individual source of data from EMR, it acted as our baseline. So we have like 5 different baselines. How good the prediction how accurate can the prediction be from each of those sources? And what if we combine all of those pieces of information into fusion models? Then how do these fusion models perform? So late fusion, this is what the structure of the model looks like. We have 5 different modalities. These modalities, they go through pre-processing stage where they are encoded. I just talked about how lab values and procedures and comorbidities and medication, etc., they are all turned into features. So we get feature representations, and then each of the feature representation, it goes through a separate classifier trained only on that source of information. That classifier makes its prediction for the output, probability of that prediction. It's taken from all of these different sources and concatenated. This results in another kind of feature vector that goes through the final meta learner or meta classifier, which bases its prediction based on the probabilities of the output predicted by individual data sources. So this is what late fusion looks like. Late fusion, it has its own challenges. It can miss, fine details of each of the information source separately, because it's not looking at each individual, for example, each individual demographic feature. Final predictor is not looking at those individual factors. It's just looking at the probability predicted by those factors. So there's a chance that it misses out on some of the important factors hidden in each of these data sources. Then we had this early fusion model. We once again have those 5 information sources. We encode them based on the procedures that I described. And all of those feature vectors, they are just concatenated and passed through one classifier. In this case, yes, the final classifier, it is looking at each of the individual factors separately. But it's looking at a huge, very large feature vector. So dimensionality of the problem is huge. There is a chance that model would suffer based on this high dimensionality. Then there was this middle fusion model. We used a branch neural network model where we basically tailored each branch based on the specific specifications of each data source. So demographic, medications, comorbidities, procedures, and lab results, they go through each separate neural network branches. Each branch design is tailored to the basically dimensionality of each information source separately. In all of these branches, they result in some compressed featureization of each source. Somewhere in the middle of this network, these representations are concatenated, and then they are passed through a final neural network branch. And there is just one loss used to train the weights of this final neural network layer and these individual branches. So this is middle fusion. Middle fusion, as the name suggests, is kind of in the middle of early and late fusion. So I'm going to talk about the results of our study. As I mentioned already, basically each of the individual information sources for EMR, they were acting as our baseline. So we made prediction based on separate information sources, and then used our 3 models: late fusion, early fusion, and middle fusion. I hope you can see early fusion seems to be our best performing model. I mean, in literature, there are certain demographic features that are supposed to be, for example, race or age, which are supposed to closely correlate with the severity of the outcome or the severity of the disease. But individually, in our case, the demographics-based predictor, it performed poorly with average precision of about only 69%. Early fusion was our best model. Late and middle fusion, they're close to our early fusion model. These the AUC-ROC curves. Once again, early fusion seems to be our best model. Demographic prescription. Individually, I think CPT is out of individual data sources, CPT seems to be the best performing model. These are the results in terms of precision, recall, F-score. Once again, early fusion and late fusion. So early fusion is the best performing model with 84% F-score. As you can see, late and middle fusion, they come very close to the performance. Late fusion is kind of always limited by the fact that the final predictor is not looking at individual sources from each information source. It's just looking at one predictive probability from the whole source. Middle fusion, we did do a grid search-based hyperparameter tuning, and that brought results very close to the early fusion model, about 82% F1 score. We still believe that if maybe with the larger data set, we may be able to tune middle fusion model to maybe perform better than the early fusion model. But in the current state, this is what our performance looks like. Since we wanted basically a comprehensive analysis of what factors may be important in predicting the trajectory of the disease, so we obviously did feature importance analysis. This is the feature importance analysis of our late fusion model. As you can see, CPT seems to be the most important factor. CPT, past procedures that the patient has gone through, and demographic in this case individually doesn't seem to make doesn't seem very important for our late fusion model. This is the feature importance from our early fusion model. Early fusion model is looking at a huge feature vector. So these are just the top few factors that based on the feature importance assigned by our model. In this case, again, you can see it kind of correlates with the literature available on prediction of COVID-19 disease trajectory. There is the history of hypertensive disease, history of lung disease, which seem to be important while predicting the outcome of hospitalization. There is the D-dimer level in the current scenario. As you can see, there each one of these factors, it's tagged by either current or history. That's dependent on which interval this value is coming from. So hypertensive disease or lung disease, it may be present in both history and current intervals. Which one seems to be more important when it comes to making a prediction about hospitalization of COVID-19 patients? It looks like historical information basically about hypertensive disease and lung disease seem to be important. And current lab values, they also seem important in terms of prediction. An interesting, I think, observation was that emergency room visits, they count for a lot. These are part of the CPT information, obviously. So that's probably why overall CPT is getting very high feature importance in the late fusion model, because it contains that emergency room visits. Overall, probably if you have had more emergency room visits in past, that probably indicates poorer health and potentially poorer outcome for the disease for COVID-19. Obviously, with any predictive model, calibration analysis, calibration plots, reliability analysis is important. So we performed this calibration analysis for all three of our fusion models. Once again, after we performed isotonic regression basically for calibration, and after that, early fusion seems to be the best, the one which comes closest to the perfect calibration with the lowest Brier score of 0.116. Late fusion seems to jump around a lot. middle fusion is again. We were interested in race-based stratification, how our model is performing for different races. So as I mentioned in the beginning, when I was describing the characteristics of our cohort, most of our patients, they are African American. About, I think, 56% patients, they come to be, they are African Americans. The second most common race is Caucasian. So we stratified our model performance based on race and ethnicity: African American, Caucasian, and Hispanic, three most common groups. We did not see much of a difference based on different race or age. So our model seems to perform pretty much equally well for different races. However, we do have this uneven distribution of different, uneven representation basically available in our data set. That might be an issue with the races or the ethnic groups, which are not very common in the data. For example, there are about 3% patients who are Asian. So that might result in poorer performance of the model over this. We experimented with lots of different classifiers. We ended up using simple traditional classifiers. They seem to be better, especially with late fusion, because with late fusion, you have basically, you end up with like 5 different probability features. In general, in our experiments, it seemed like decision tree based models, traditional decision tree based models, they seem to work better. In our case, I think the best one was XGBoost. Yeah.
So only middle fusion used
Yes.
on neural network.
Yes, I did try a neural network based model for early fusion as well. But it turns out that XGBoost, at least for this cohort of data, XGBoost was performing as well as any a more complex neural network. We did do extensive hyperparameter tuning for our branch neural network for middle fusion. Tried different structures, different, basically depths of different branches. The best we could come up with was like very close to our early fusion model performance, but could not really beat that. Might be because of the smallish amount of data that we were using. If I'm assuming that with the larger cohort, middle fusion may generalize better than earlier late fusion.
I have a simple question. So in the labs results section, when you were generating the features, did you ever look into, let's say, instead of doing abnormal versus normal, did you look into above normal and below, like adding a more fine grain split, or?
No, for the current modality, we simply base them basically being inside the normal range or being outside of the normal range. I think coding it as high or low, or like high for a lab or low for any lab, they would mean the same thing. I'm not sure if I can, I mean, high of, let's say, lab 1 would be bad as compared to high of lab 2. I mean, the notion of high and low versus what's worse may be different. I'm not sure. It depends. I think depends on what kind of lab. If all of the labs high means worse, then probably you should go for high, low, and normal. But if in some labs it's just normal versus abnormal can work better. I think it comes down to what kind of labs we're looking at.
Okay, makes sense. Thank you.
I have a question related to this temporal window. So in your first study, how do you choose like the window of the current encounters? And do you do like experiments or studies to see the effect of the window?
We did experiment with different temporal modeling techniques, week by week, month by month, quarter-based interval. But as I mentioned, the data set was very specific in the sense that some patients have lots of information available. They've been coming to the same centers for years, so we have information about them. And then there are patients who don't seem to have any information beyond the very recent days before the RT-PCR testing. I think I would say the answer is based on experimentation. We came up with this, and also the period would be about 14 days for the virus. So whatever is happening within the past 14 days might be important. That was a factor, but then it was kind of validated by the experimentation.
Okay, I see. Thanks. There any other questions? Okay, if not, let's thank our speaker Amara, and if you have further questions later, feel free to under the YouTube video or in the Google form on our website, and we'll follow up on it. All right, thank you everyone. Just a quick reminder that there's no session next Thursday. We will meet again the following Thursday. So let's take a break and yeah. See you in 2 weeks. Thank you, everyone. Amara.